I am not a mathematician or a stats person, although I have great respect for math theory and math modeling. I think I did check Google once for my name, and I came up with a female basketball coach in Florida, so I'll take claim to that. So I'm going to give you, I guess, more of a big view towards people and people as systems. And I'm going to talk a little about some higher order quality issues in terms of influencing quality and safety, as well as give you a couple of more detailed issues about what I've been involved in a little more recently. So this is a nice quote that actually came from the president, I believe, of the Joint Commission, who said that in all of healthcare, this was related to a pain project that Dan and I were involved in, that we need to transform healthcare to a high reliability and quality and patient safety with rates of adverse events and breakdowns in safety processes comparable to the best reliable organizations in the world. And this was just following the Joint Commission's trip over to nuclear safety. We went to a few nuclear safety commission in the United States, and we're trying to look at similar parallels for what we can do in terms of looking at healthcare systems compared to those types of parallel universes, I guess. I think, Dan, you probably should have had this paper in your stack this morning. When I think about quality and safety and changing institutions, steering the ship, I always come back to this very small paper published way back when. This is really the foundation for quality improvement in pain. Mitchell Max was a brilliant man who penned this paper that said, why is it that 20 years of stellar efforts in this country have failed to improve the quality of pain way back in the late 80s, early 1990s? And it was that we were really failing to look at the context of what the situation is. And I think we've heard a lot about this today. We need to have some visibility in terms of feedback. We need to have some accountability. Certainly we need some practical tools. And that just simply bean counting, holding a standard up there, quality assurance, if you will, was the model, really didn't help us understand why we were failing or how to move forward. So Grimshaw and Rao have published quite a bit over the years, really nice technical assessments showing that 20 to 30 to 40% of patients don't receive evidence-based care. Much of the care that is delivered can be harmful. And they really said that any kind of planning for any systems change really needs to consider the nature of the intervention, the characteristics of whether it's the patients or the providers, and very importantly, the socio-cultural, political context that you're operating in. I think you all know culture eats process for lunch if you don't understand those factors. Even simple awareness of innovations or the nature of the innovation, what's sexy, what's appealing, if you're introducing a new drug or a new drug delivery system, that's very different than trying to engage professionals in terms of patient teaching or patient counseling. So I'm going to just have a few slides about system science. I knew that Sean would show you a few of some of that in terms of registries, but I think when you're looking at training an institution or improving quality, implementing evidence-based practice, we have to appreciate that we all work in very complex systems, and there's a lot of principles that can apply to that. These are systems and people's practices, behaviors, attitudes that change over time. Some of this is tightly coupled, very policy resistant. It's a non-linear, kind of counterintuitive system that we work in, so you have to take into consideration those factors. I really have always liked to try and learn from other successes and failures. How have we improved care in terms of infectious disease, in terms of diabetes? What other sciences are out there that can help us learn? And I happen to run into this. This is my connection to one of my kids who's kind of one of those permaculture, save the world kids and does a lot on urban gardening and such. But if you think about system science, particularly like shaping a root system, there's a lot of evidence that we have both primary and lateral root systems that are affected by many different factors. And certainly this is plant science, but I think if you think about the systems that you work in, what is it that drives people's practice, and understand that there's different rates of growth and different contributions contributions to all of those. I was giving Christina Feldman a little grief for kidding this morning when I said she's kind of the sprinkler system for us, and she has been in the United States with getting our lateral and primary systems to grow by funding innovative ideas and programs and practices. So system sciences, as I think you heard from certainly Dr. Mackey, really can offer a little insight into the whole that you can't get by just studying an individual person or an individual variable. And it encompasses a very wide range of methods of some of this analytical science, and I can't even pronounce some of this, but it's pretty remarkable. Because of the time shortness, and I talked to Dan a little about these slides, I took a couple slides out, but there is some interesting papers published using some of this modeling, like simulated dynamic interventions for education, for looking at reducing opioid deaths in the United States and chronic pain. And if you can leverage one change, what will be both the intended and unintended consequences. So, you know, without using data and having to go through that, you can do mathematical modeling and put things in to really give you some idea about which direction you should go or what you should push. The Institute of Medicine and others, the Institute for Healthcare Quality Improvement in the United States, has really given us kind of that bigger 60,000-foot look in terms of what is it that influences quality. And I think that we are all driven and engaged in various aspects of this, but again, take a step back and look at not only the patient experience and the aims of the 6 primary aims of quality, but looking at the micro and the macro system. And again, this environmental context with financing and regulation and accreditation that can really drive people's behavior and how your organization is put together. Again, this is another grand lecture, but I think this really makes a lot of sense. And this was from Crossing the Quality Chasm probably more than 15 years ago now. But if you're looking at improving quality, this is what we need to do. We need to redesign care based on best practices. And how do you do that in an efficient way? We're very much, I think, still underutilizing information technology. I think the Institute of Medicine way back when said, it's as if we're trying to break the sound barrier by tinkering with the Model T Ford. We're just scraping the surface, I think, about what information technology can do from us. We definitely need to improve workforce knowledge and skills and help these people develop into effective teams. A lot of what's coming from the Institute of Medicine in the Institute of Medicine's blueprint in the U.S. Drove the Centers for Excellence in Pain Education, where we're trying to change how we prepare pre-licensure disciplines across in terms of how to work in teams together, how do we coordinate care, and then again, this very important issue, how do we use data from real life to learn? How do we measure and improve outcomes and feed that data back into the system? Most of my work has been involved in trying to look at how do you infiltrate the system, how do you integrate things into the system. I'm going to talk primarily about institutional models as an example, but there's a lot out there. The clinical pathways, if you look at the map of medicine, which you can go online and register for that, that's a really interesting project. They have 5 very nice large maps for different chronic pain conditions, including pelvic pain and fibromyalgia, to give you some information about how this can work in a system. The Joint Commission is probably one of the bigger drivers, at least in the United States, in terms of trying to affect this. They've done lots of work, and I'm going to just share with you a small example of a project Dan was involved with a couple years ago, but they've really said these kind of 4 things, that we need to really think about, do we have effective processes? Are we using technology in a safe and effective way? And that includes communication as well as pump delivery systems and such. Do we have the appropriate training and education? And again, back to Mitchell Max's comments, what are the practical and effective tools, and can we use those and engage those in clinical practice? So this was the project that Dan and I and Judy Pace were involved in a few years ago. Joint Commission Resources set out to try and help develop some resources for hospitals on how to improve quality, and it was really focused on the perioperative continuum. So what they did is they actually went out and visited 6 hospitals in the United States, 3 very large academic centers and 3 small community hospitals that were known for doing things right or having good outcomes, and really tried to outline a systematic approach and try and talk about ways that we could standardize across the system, ways to do that. That was that little card that Dan held up. Comes on a little thumb drive, but you can go online and you can download this for free. It's actually kind of about 4 chapter-like things, but it's got lots of tools and examples from these hospitals and some basic principles. And they very much leverage their Six Sigma Institute for Quality Improvement to do this. In summary for this project, what they really said is that if you're looking at processes for improving care around perioperative acute pain, that you need to really understand the map, understand the system, and you need to keep it simple. You have to look at what is it that 80% of people get. What's the 80%, that 80%-20 rule? We're not looking at the most recalcitrant, difficult population, but let's get it right for the majority where we can standardize. So again, there's tools in there about going in and mapping the process as it currently exists, going out and finding out what are the leading best practices that you have in your organization, things that are the low-hanging tree, apples that you can go out and improve, but certainly having stretch goals, looking at what is the ideal state based on how that matches with your current state. Now, I think I got some instructions as a speaker at IASP not to use jokes, but I know everybody's sick of quality improvement. I think when I first went to quality improvement, it was like going to a bit of a cult training. You know, they locked you in the room so you couldn't go out or answer your phone unless you would do that if you were 100 miles away. But again, there is some beauty in this, and I think there are some lessons learned. So remember, quality improvement is evidence-based in terms of using data, not gut hunches. It does what I think we've heard a lot of today, and that is bringing teams together, bringing different perspectives, valuing diversity, which is what you need to do if you're trying to move things forward, different perspectives. So it really asks these important questions about what are we trying to accomplish and how are we going to know that a change in what we're doing really does lead to improvement. Here's just an example of quality improvement in acute pain from an emergency department looking at type of analgesia in children with long bone fractures. Very nice, simple quality improvement study where they leveraged the 4 key drivers of that process. Standardizing the initial assessment of what type of injury when the child entered the emergency room, having staff awareness of that this was an issue for improvement and how to improve it, standardizing the order set, and aligning resources and personnel. And again, in a parallel universe, there are some papers published just on simple hand hygiene that many staff are not aware of it. So just addressing simple awareness can be a huge facilitator of change. This is a little Don Berwick's from the book Escape Fire. I don't like to read a lot of books around work, but I would highly recommend if you've never read his book. It's a series of his speeches for the IHI. And he really talks about some basic principles. Standardize what is standardizable and no more. And I heard a little of that this morning. We can't always standardize everything. We need to generate light with our data, not heat, which is the old QA method where you kind of have a standard and you kind of whip people into submission if they weren't meeting the standard. We need to make the right thing easy to do and the right thing easy to try. So how can you, we're doing a project in our recovery room at Harborview now where we're trying to get noise reduction music right at the bedside and at the PACU. So how can we make that easy to do and easy to try and as well measure the outcomes? Just a couple of other local resources. The University of Washington has this thing called Occam. It's an online clinical decision center and algorithm messaging center. Most of the residents at both the medical center and Harborview, which is the trauma hospital Brendan and I are associated with, use this on their iPhones where they go and look about how to do antibiotics or how to do blood transfusions. And so we now have an outcome on perioperative multimodal analgesia for major surgeries. And I have a copy of it. I'll pass it out when I'm done. It's a very short 1 or 2 page general principles to help teach the residents a general approach. We also have a collaborative pocket guide like most hospitals have. And this is really more of a stepwise for residents that are stuck with acute pain on post-op number 1 or 2, who've been calling the pain service and saying, my patient's maxed out on their PCA, I don't know what to do, and yet they don't even know what the PCA settings are or how much the patient has used. So it gives them some stepwise information about how to tackle that problem. Many of you probably know or are already very engaged in a lot of the ARAS movement to enhance recovery after surgery. I think these are great catalysts to bring teams with different perspectives together to really achieve a greater good. I mean, there's no question that I think we get a lot more leverage from participating in these interdisciplinary teams. And again, this is an example of one engaged at the hospital I work, which is trying to improve recovery after major spine surgery. And so we have scripted some patient education for both the patients and families, as well as the staff who are counseling those patients preoperatively. We're developing some preoperative consultations with the pain service. And then that's just kind of a snapshot of the power plan or the precision orders that go through multi-phases to, again, try and steer the residents into the right direction. So, why do hospitals succeed in changing anything? This is, again, a very old seminal but classic paper presented at the first Joint Commission AMA, it was APS Pain Summit way back in the early 2000s. This was a very nice study looking at why do some hospitals succeed in use of beta blockers when others don't, when there was plenty of evidence-based guidelines, there was plenty of information about how to do that, there was a core measure. It really found that it was a lot of just qualitative measures, good leaders, having a shared goal, having people understand what it is you're trying to do, having strong medical staff leadership and using data in the right way, credible way that provided the feedback. So this is, I think, really my last slide, and again, it's, I think in terms of improving quality, changing practice, you really have to understand the process of change, whether it's Rogers diffusion or this happens to be Cotter's step, but changing quality, changing people's behavior really is about relationship building, it's about persuasion. There's a very thick literature in terms of change, and I think you've all seen it, just like quality improvement, you're like, oh gosh, now here we go again. But just like it takes 15 to 20 years to put something into practice, there is evidence that it takes 5 to 10 years for changes to stick. So you can't declare victory too early. You really have to understand creating this urgency for change and using data and rewarding feedback or giving people a positive